movement in this particular area, and what is it that has taught us not only for preparation for future pandemics, but also to carry forward to say the NCD movement. It's my pleasure to invite on stage Dr. Professor Amitabh Banerjee. He's a professor of community medicine, D.Y. Patil, University of Medical Sciences and Research, and he will be chairing and moderating this session. We welcome you, sir, to the stage. And if I can have his introductory slide. Okay. So Dr. Banerjee is the professor in Department of Community Medicine at D.Y. Patil Medical College and Research Center. He's also the editor-in-chief, medical journal D.Y. Patil Vidyapeeth, and the academic editor of PLOS1. He has formerly chaired the IEC NIV Pune, presently chair IEC AFMC Pune, and has over 200 publications to his name, boasting almost 3,462 citations. He's also ranked amongst the top 2 scientists globally in Stanford University Researchers List 2023. Welcome, sir, and over to you.
Thank you. It's a pleasure to be on this platform to get the patient's perspective, as I keep telling that I've been hearing the patients also and the doctors also. I find the patients more interesting. The doctors are just giving what's written in the textbook. Patients are giving the very original first-hand information. So that's the great thing. So it's my pleasure to invite the panelists. We have got a very eminent group of panelists for this session. Post-lunch session, I'm sure you will find it very interesting. Dr. Kuldeep Singh Sachdeva, he has worked in TB for many decades. He's an authority on tuberculosis, regional director, Southeast Asia, International Union Against Tuberculosis and Lung Disease. He has worked in the ministry, he has worked in public health. And in fact, I asked him what he is going to speak on. He said he doesn't know, neither I do know. So it's a double blind. And because being an authority, they don't have to, they just speak from the experience. So it's going to be worth it. Dr. Kuldeep Singh Sachdeva, sir, please join us. Similarly, we have got Dr. Manoj Kumar Pardesi. He's worked all his life with people living with HIV/AIDS. He's the founder member of National Coalition for People Living with AIDS. And I know him for almost 7-8 years. Half of the time he is in the Northeast, which is the hotbed of it. So he will be also sharing the patient's perspective, because this is a very social problem, more perhaps than a medical problem. So Dr. Pardesi, sir, please join us. Then we have got a online expert, Dr. Danjuma K. Adda. He is speaking from Africa on hepatitis C. Hepatitis C, you see, most of these panelists, they are connected. HIV, hepatitis C, then tuberculosis, because immunity goes down, tuberculosis surfaces. And then we have got a fourth speaker, Dr. Sanjay Sareen. He is into diagnostics. So for diagnostics, innovations in diagnostics, so all these are required to diagnose the disease. And shall we start with the, I was told Dr. Sanjay Sareen would like to speak first. Dr. Sanjay Sareen, you may start, please. Okay, there is a opening slot ke liye, there is a competition. I was to Dr. Danjuma K. Adda. He would like to speak first because he has some commitments, followed by Dr. Sanjay Sareen. So, Dr. Adda, please, we welcome you. Please give your presentation.
Thank you so much. And I really appreciate this invitation. And it's indeed an honor for me to speak at this very important meeting. So my name is Danjuma Adda. I'm the president of World Hepatitis Alliance. And then I am also a person living with hepatitis B. So the World Hepatitis Alliance is an international, so the next slide. The World Hepatitis Alliance is an international network of patients and community groups across the world. We drive advocacy and drive awareness about hepatitis. We are led and governed by people living with hepatitis. As in this instance, I'm also a person with hepatitis B, and I lost my mother to hepatitis C in 2007, and actually that was my motivation for starting the charity work that I do. So we raise the voice of people and communities affected by viral hepatitis, calling for urgent action to see the elimination of viral hepatitis by 2030, because the World Health Organization have set the goal of eliminating hepatitis by 2030. The next slide, please. Though I will actually speak more off from my heart rather than really from the slides. So if I don't ask for next slide, you just bear with me, because it's more of a sharing my personal story and then the challenges faced by hepatitis community. Now, globally, hepatitis affects over 296 million people across the world for hepatitis B and over 96 million for hepatitis C. Diagnosis and treatment is uneven. As a matter of fact, only 2% of people, especially for LMICs with hepatitis B, have been diagnosed, and 0.1% are placed on treatment. Whereas for hepatitis C, about 13% have been diagnosed, and only just about 12%, 5% have been treated. That is even from just one country, which is Egypt. The World Health Organization have set a goal to eliminate hepatitis by 2030. And the goal is to make sure that 90% of people with hepatitis are diagnosed and 80% are placed on treatment. That is a very laudable, ambitious goal, which is not impossible to achieve, but it seems very difficult to achieve because of the poor commitment and lack of political will by countries and national programs towards achieving this goal. Next slide, please. Now, this is a cascade of care. I've talked about it earlier, about hepatitis across the world in terms of care, testing, and diagnosis and treatment. Remember, the goal is 2030 to reach elimination. But as it is now, very little has been done in achieving in diagnosing and even achieving treatment. And hepatitis C is curable, and this is one thing that bothers and touches the heart and head of some of us. Hepatitis C is completely curable with 3 months or 6 month treatment. Hepatitis B has an effective vaccine that could be administered either at birth to babies, and that will prevent infection, and there's an effective treatment. But the challenge remains, how do we diagnose more people? How do we place the pills and the medicine into the stomach of patients? So the missing gap is between diagnosis and treatment. And that is a major gap that needs to be closed if only the elimination goal by 2030 can be achieved. Next slide, please. Now, there are a lot of obstacles that faces a patient community, especially people living with hepatitis, towards living optimally their lives. One is stigma and discrimination. It will be very difficult to achieve the elimination goal of hepatitis B or C because of stigma. People are stigmatized, people lose jobs. As a matter of fact, in some countries in Asia, people don't get visas to travel if they have hepatitis. People are diagnosed with hepatitis are sent out of jobs in families. People with hepatitis are not even accorded the rights that they deserve as living beings. And that is a very big problem to be overcome. I know when I was personally diagnosed with hepatitis, it was very difficult for me at that point because hepatitis seemed to be like a death sentence. So majority of people are internally stigmatized, and even stigma in the social sector, stigma in the workplace, stigma limiting people from achieving their life ambitions and life goals. And hepatitis, to be honest, is like the neglected child in the home, whereas the older siblings are getting so much attention in terms of funding, in terms of care, but hepatitis is so neglected. The next slide, and that will now show some of the barriers the community experience. So there's a lot of equality. In the context of universal health coverage, of leaving no one behind, hepatitis B is neglected. Hepatitis C is neglected. This is a disease that is curable, a cancer-causing infection, but there's very little in terms of care, very little in terms of diagnosis, very little in terms of support, peer support, or even testing and treatment to achieve the goals of elimination. Next slide, please. Now, stigma, I've mentioned this, out-of-pocket cost is a very big challenge. Most countries and programs do not have health insurance, and so patients have to pay out of pocket. There's very poor political will across most countries in achieving elimination, and inadequate testing and diagnosis. There's low awareness of viral hepatitis. There's very poor global and national investments towards hepatitis elimination. And yet, this is a cancer-causing disease. 70% of liver cancer is caused by hepatitis B and about 15 to 20% by hepatitis C. And yet, there's very poor investment, very poor support in terms of testing and even diagnosis or treatment for people with hepatitis B. So I'll round up by saying, to achieve the goal of elimination by 2030, we require collaboration among clinicians, collaboration among patients, collaboration among communities. To achieve elimination, services need to be simplified, services need to be decentralized, because the WHO set a goal of people-centered care. Person-centered care cannot be achieved if the lived experience of patients and communities are not integrated into co-creating healthcare. And that is a big challenge we have in most programs. Patient voices are not included in co-design of health programs, in co-design of treatment guidelines development, or dissemination of guidelines, or even implementing services. Whereas the global sector strategy for hepatitis and HIV clearly talks about empowering communities. The hepatitis community is so disadvantaged because patient communities are not actively engaged. They're not actively engaged to amplify the voice, and even for peer navigation, or even for community services. So for the elimination to really happen, there's need for patient empowerment. There's need to make the patient to sit in the driving seat as part of the healthcare system, as part of the people that will co-create the health services that is meant for them. So achieving elimination is possible. We have an effective vaccine that can prevent hepatitis if babies are given this vaccine at birth. But this is not done across the world. Most babies are not given this vaccine within 24 hours of birth. Hepatitis C is curable with effective direct-acting antivirals, 3 months treatment or 6 months treatment. But most patients do not still have access. They have to pay out of pocket. And this has driven many people into catastrophic poverty. So this has to change if only there is increased programs, and we ensure that patient voice is adequately captured and patients are empowered to really be in the driving seat towards working towards achieving this elimination goal of hepatitis. So we can do it if all we work together as clinicians, community, government, policy, industry. If we all collaborate and work together, we can achieve this goal of eliminating hepatitis. And as a person living with hepatitis B, I can tell you there's a mental torture to this. So patients need to be empowered. There's need to break down this stigma so that patients who live in hepatitis, either B or C, can live a fulfilled, happy life without the fear of, being deprived of services. So thank you so much for this opportunity. I'll round up by sharing the opportunity we have for the World Hepatitis Summit. Can you go to the next slide? We have the World Hepatitis Summit coming up next year in Lisbon. Please, you can sign up to our website and register and be part of this. And I'm happy to be here. I'll sit back for the next few minutes if there are questions or comments, but the hepatitis community is happy to be part of this. And thank you so much for giving us the opportunity to be here. Thank you so much, and over from me.
Thank you, Dr. Adda. Very good summing up. And just one question I'll ask you. Like, what is the cost of antiviral for hepatitis C? I believe it's very costly in the Western countries. India, it is quite cheap. What is the situation in Africa cost-wise?
Now, hepatitis C treatment depends on where, but there is a negotiated price of $60 for 3 months. And that was the negotiated price in Geneva by the Hepatitis Fund and then other partners. But the unfortunate thing is that that is a cost at production level. Before it goes to countries and before it gets to the patient, the middlemen, the country people increase prices. And at the end of it all, patients in LMICs might get that drug for like $200, $300. Whereas the cost at production level should cost less than $50. And yet we're talking about communities that are living less than $1. How many people can afford to buy hepatitis C treatment for $250 or $300 as it is in most of LMICs, like Africa, where I come from? So that is a big gap that needs to be addressed. And I hope that maybe if there are industry partners here, they will be able to tell us how best we can get the medicine, because the most expensive medicine is the one that doesn't get to the stomach of the patient. And we have so many people dying of liver cancer because they cannot afford this treatment. Thank you, and over from me.
Thank you, Dr. Adda. We regret that Dr. Sanjay is not able to join for some reason. So I request Dr. Sachdeva to give his presentation on tuberculosis.
Thank you, sir. I don't have a presentation per se, sir. So primarily, I can talk about TB elimination or TB control, whatever the other countries call it. Just to give you a perspective, TB, they say it's almost a 20,000 year old disease. So the one good news is that the very fact we are thinking about elimination now points to the fact that there are now tools available by which we can think about TB elimination. So that's a scenario which is optimistic. And the tools which are available are both managerial tools, public health tools, as well as more better drugs, better diagnostics, and diagnostics which are very sensitive, specific, drugs which can almost cure you 100%. Even for now, for drug-resistant TB, you expect around 90% of cure for drug-resistant TB, which used to be about 40% about less than 5 years ago. So huge developments on science, huge developments on management science, public health, huge interventions on public health side, which have at least made us think that we can eliminate TB in near future. And that is what the global targets are saying. Even UN Sustainable Development Goals say 2030. India said we will try and eliminate it by 2025. Now, the basic interventions for TB elimination, again, some of the old one is early diagnosis, early, quick, and a correct diagnosis, then early treatment. So those two still hold true. Added on to those basic interventions are now, first I'm talking more on the science part of it, are now what we call as TB preventive therapy. And we also have a vaccine in sight in near future. We are looking at vaccine globally to be rolled out by 2027 or maybe end of 2027. So there is a huge hope on vaccine side also. On the managerial or the public health side, how do we increase access to patients? So within TB program, there has been huge focus on engagement of private sector. How do we get patients from private sector? So especially in our country and our part of the world, which is Southeast Asia, we see a close to 50% of patients being seen in the private sector. And that was a huge gap which was existing about 10 years ago. And I recall when India started rolling out private sector interventions in 2012, 2013, the first year we could only reach out to around 3,000 patients. And last year in 2022, they reached out to 700,000 patients from the private sector. So huge buy-in with the private sector, huge interventions on the private sector side, and also the national program supporting private sector engagement in the form of putting funds for private sector to reach out to patients. Also allowing all public health actions free of cost to private sector patients. So that's a huge plus on the public health side that they've shown that you can increase your reach. And now, at least in India, the gap between estimated and the what you detect is narrowed down a lot, and we roughly miss around 300,000 patients now, as against 28 lakhs or 2.8 million patients. Program is able to reach about 2.5 million patients. And if we see about a decade ago, that was close to 1.5 million. So huge gap has been bridged by experts, public health experts, and the suggestions from the public health experts. Also, with the onset of when we saw the COVID pandemic, we also saw a huge mobilization from all stakeholders. We also saw a huge mobilization by patients, interest by patient advocates, and also by community to increase accessibility to services. So another intervention called community engagement, or call it patient engagement, we call in India, we call it engagement with TB champions, which is patients who have been cured of TB, has also seen increase in access to a large extent. And if you look at the national program now, specifically in India. So close to about 30,000 TB champions are involved in the program. There is a huge all state, districts, and even blocks have what is called as TB forums, which are again led by TB champions or patients or patient advocates or TB activists or TB Vijeta. The various names have been coined for that. So that's another intervention. Also, huge political buy-in, and that's one of the major plus which we see in many countries now. I have seen even Prime Minister of Timor-Leste saying that they will eliminate TB by 2025. India, of course, has committed to eliminate TB by 2025. So all this has led to a huge interest, advocacy, and a huge mobilization of resources. TB program alone has seen its budget almost tripling in last 7 to 8 years. So the budget has almost gone by 3 to 3.5 times what it used to be in 2015 level. So generally we track all our indicators from 2015 level now, once we have achieved the Millennium Development Goals. So what we have seen is a huge increase in funding. Whether that's still sufficient or not is another question, but that has seen an increase of almost 3.5 times from the 2015 levels. Also with this huge political advocacy, another intervention, again a public health one, which is rolled out, it's called Pradhan Mantri TB Mukt Bharat Abhiyan, or it's actually people's movement against TB, where any individual, organization, government servant, private people from private sector, all walks of life have been given a clarion call to adopt TB patients while they are on treatment, offer them livelihood support, offer them treatment support. And now with the help of about 100,000, what we call as Diksha Mitra or Friends of TB, almost 1 million TB patients have been adopted by them, and they are, it's like hand-holding patients in their journey towards a logical cure from their disease. So we see a huge movement on the patient side, and as I see, this is a patient summit. So involvement of patients, communities, and other stakeholders. We actually have drawn what Manoj will talk about it is from the HIV program. So HIV program was one of the first program which showed huge involvement of people affected with the disease. Same was later scaled up to TB program. And now even TB program boasts of involvement of patients with disease to a huge extent. How much of budget or funding is going into that? Now, now about 1 to 2% of overall national budget goes towards engaging with communities, which is a national budget. And outside of what we call as extra budgetary or not coming from the national government will be another 3 to 4%, which is now dedicated towards involvement of patients and communities. And they assuming the charge of taking their own health in their hands and seeing to it that all patients are reached and that they reach their logical end of cure, and the journey is also very smooth. So they not only ensure cure, but they also ensure that the journey is seamless, a smooth journey, and they don't have to undergo many challenges in that journey. So that's also a huge plus which we have seen. So these are the public health interventions which are playing a huge part towards TB elimination. Where are we now? So if we see, India still remains a high burden TB country. But if we compare ourselves with the global achievements, in reduction in incidence, we are almost, again, I'm using 2015 as a benchmark. So our reduction in incidence is almost 18% versus 8.7% global reduction in incidence. So you see the huge advocacy by bureaucrats, politicians, patient groups, TB champions have actually enabled you to extend resources to a large extent, engage with the private sector and show you that accelerated decline in incidence is possible if you involve all stakeholders and try to work towards a common goal. So similarly on mortality, we are matching with 28% reduction in mortality. What we still have to match is reduction in catastrophic or out-of-pocket expenses, which still remain very high in our country. And there is another intervention which is called engaging with the private for-profit sector to contribute them towards the TV program, what I call as extra budgetary resources. So almost now 400 for-profit corporates are contributing resources either in kind or in cash with the help of various civil society organizations to help TV program achieve its goal. So again, a huge intervention, again guided by public health experts, demanded by patients. So there is a huge voice there. And we have been able to extend and show that kind of a support to the national program that yes, we are there with you and we will walk this path together. So that's again a very strong public health movement which is occurring, and it's called in our Hindi we call it Jan Andolan, or it's a mass movement for TB amongst the population. So that's again a movement which is so we are on the right track. We are all geared up to be there. Yes, there may be implementation challenges, there may be some shortcomings in implementation, which we can discuss, and we can always try and improve those implementation challenges. We can saturate our existing interventions. We can roll out future interventions in a more logical, rational, well thought out manner. But we are prepared to meet this challenge head on. I think, sir, I'll end here and
Thank you, sir.
I'll wait
It's
for
very exhaustive and
questions,
very
clarification.
first-hand experience. I have just some doubts as an old school. Actually, when we were in, earlier days, we used to say that tuberculosis mein infection does not mean disease. Like 30-40% Indians are carrying. So I was just wondering whether hope we are not going to overdiagnose people who would not have progressed to disease. I mean, this was a teaching, old-time teaching. People carry infection, but everybody is not disease. So any thoughts on that, sir, vis-a-vis the program?
So major change which has occurred within the TB diagnostic algorithm is that now they don't rely on a single test or a symptom to say that you have a TB disease. So they have put in an algorithm which increases the sensitivity, and also at the same time, you don't diagnose false positive, you don't rule out false negative. They have put in checks and balances. So like, if you remember, sir, olden times we used to have mass miniature radiography.
Yeah, exactly. That was
To
discontinued.
diagnose TB.
Yeah.
So what has changed now? We still use X-rays to diagnose TB. But what has changed now is in 1950s and 60s, X-rays were used as a diagnostic tool. But currently X-rays are used as a screening tool. So they are not used as a diagnostic tool. So once you use X-rays as a screening tool, what you are trying to do is, and then with high sensitivity. So X-ray have a very high sensitivity. There'll be large number of false positives on X-rays. Now, how do you rule out false positive? You follow it up with another diagnostic tool, preferably test, a smear or a sputum test, a molecular test to rule out TB. If you cannot get sample, then you use clinical symptomatology and other things to rule out TB. You also look at other adjunct supporting investigations. And currently, if you see, sir, almost 80% of patients have a microbiological diagnosis. We still use clinical diagnosis to some extent, 10 to 20%. But that's when the patient is sick, he's showing all the symptoms of TB. So to a large extent, the problem of overdiagnosis and underdiagnosis, we are trying to take care of this. The microbiological diagnosis is very sensitive and specific. A new molecular test like Gene Expert, TrueNat. We also have further now one more test called PathoDetect, and a host of PCR platforms which were installed in COVID can also do a TB testing. So all this, an algorithmic approach has helped us to actually find the correct diagnosis. And if you, we'll come to you. If you miss a diagnosis, you can still do culture results or other things to do that.
Second question, sir, is on the BCG vaccine. I think 2 days ago, there was a news also that they are going to see for revaccination with BCG. And as per, again, old school, BCG was not found to be very effective. So are you going to having a new vaccine or the same vaccine we are going to?
So currently there are many vaccine candidates which are in the pipeline. I said globally expect one to be rolled out in another 3 to 4 years. In India, what they are trying to do is, and what the evidence in almost 27 or 28 countries, which do BCG revaccination. Has shown that if you revaccinate the vulnerable population at adolescence or thereafter, I mean, what India is trying to do is at 18 years of age and above, you can demonstrate some reduction in incidence. And it's a complementary strategy to TB preventive therapy. So one more armamentarium in the prevention basket of TB. So the first armamentarium being airborne infection control, second being TB preventive therapy, third is they are planning to roll out BCG revaccination. And what they are also saying, they are doing it on a pilot, as a pilot learning project. So they'll have about 180 districts which will implement BCG vaccination and 180 controlled districts. Over the next 2 years, they will try to come out with some evidence on whether it's working or not, and then take it on further and scale it up nationally. So currently, it's not a national scale up. It is under the guidance of Indian Council of Medical Research on a pilot mode.
Third, last questions are very important. You have covered it in great detail. That is involving the private practitioners. Now, a lot of people, particularly in rural areas, they go to Ayurveda, homeopath, other system. Are you going to involve them also in this?
So there is a actually MOU with Ministry of Ayush. There is also an engagement with the Ayush providers at state level, district level. So there are definitive interventions on involving Ayush. They are also being incentivized on if they sort of refer and get a TB patient diagnosed. They are also being offered free drugs, free diagnosis from the program, which they can refer the samples, get a free diagnosis, and if they are diagnosed with TB, they can use the drugs which the program gives them. So huge involvement of Ayush practitioner, and even beyond Ayush, they are also involving other practitioners. So Himachal has, Ladakh, and those areas they have Rigva, Sopa, and other practices also, which are not listed in Ayush, are also being reached out.
Any questions from the audience? And tuberculosis is important, yeah, please.
My name is Nidhi and I'm from Singapore. I'd like to highlight the fact that the TB bacteria likes to sit in the gut also. And many people are not aware about it, including doctors. I believe a lot of gastroenterologists are misdiagnosing patients who have either Crohn's disease or ulcerative colitis, and they are being diagnosed in India as having gut TB. So is there some level of awareness being created around that?
Yes, of course. I think AIMS also did one study on gastroenterological TB. And we also, specifically in the pediatric age group, we say you can take a gastric lavage or a gastric wash or a stool sample and run a molecular test on that to get a confirmatory diagnosis of TB. It's not that sensitive and specific as with other samples like sputum, but it's still, if you get a positive test, it's a good help on your armamentarium to say with definitive strength that it is TB. Of course, clinicians still use, and we do give them a leeway in difficult cases to diagnose TB on clinical ground. So that's what I'm saying. Almost 80% get a microbiological diagnosis. But at the same time, because TB has manifestations, which are so many, we do allow some leverage to clinicians coupled with supportive evidences to use their clinical judgment along with some laboratory support to arrive at a diagnosis of TB.
One
Sir, one
thing
more question.
came to mind just
And
regarding.
just for your information, also, AIMS has developed a guidance document on diagnosis and management of extrapulmonary TB. The first edition was way back in 2016. It has just been revised this year. And again, they have used the Cochrane group to find evidences on diagnosis and management of extrapulmonary TB. It's a very good document to go through.
Anyone
Yeah.
from the audience?
Sir, one question. My name is Jay. I'm from Oracle. So recently I was involved in a research study on digital health interventions for tuberculosis. So what I found was the last 2 years, we are not using any medication adherence technologies like 99 dots, VOT. So we did a lot of pilots 3 years ago. It was found to be very useful to really track the medication adherence, but they're not really using it anymore. Any specific reason
No,
why?
all these technologies which are technology, internet-based and other technologies are actually approved under the national program. What I also referred in my initial talk is that while there are huge number of policies and interventions, not all have reached their full saturation levels, and not all are accepted by patients per se. We are here talking about patient perspective also. So while 99 dots has proven to be a good technology, what we observed is that the uptake of 99 dots by patients remains poor. And more than the uptake of 99 dots, the action by so-called providers on the signals which you get from 99 dots has been not very, very optimal, which we would desire. So it's a question of implementation shortcomings, but all these technologies are approved in principle, including medication pill boxes, 99 dots, SMS reminders. So they are part of the national policy, but their implementation does remain suboptimal.
Last question. I am taking the privilege of asking the last question.
I
Just,
had one question, sir.
okay,
So
last but one.
again, this is a learning from HIV TB where comorbidities were taken into consideration and screening done for both. So TB patient for HIV and HIV for patient. Is there any such thought process for diabetes? Because we see an increasing trend of diabetes in the country and also globally, and people with diabetes being more prone to tuberculosis.
So again, TB diabetes screening, bidirectional screening, again is a policy from, I think, 2013 onwards. So where it doesn't happen in true letter and spirit bidirectionally is because the diabetes program does not have a very good structure to capture data, report back. While all TB patients, almost 80–90% of them are tested for diabetes, and we know what is the percentage of diabetes within the TB patient. The same is not happening with the diabetes program because they are more clinic-based. So there are diabetic clinics. There are no district-based structures within the TB program. So as and when the NCD program matures and they are able to capture and share the data, it will see the true light of the day. Again, in policy, in principle, it's an approved policy. Again, a suboptimal implementation. Main challenge remains on the side of the non-communicable disease program.
Last question, that we are a country where a lot of animal husbandry, bovine tuberculosis, particularly rural areas. So we don't treat any program on that because we cannot eliminate as long as there is a extra human reservoir.
So there is a lot of studies which have gone on animal TB, and many studies have actually pointed out that we don't see much of transmission from animals to humans, but we have seen reverse transmission from humans to animals in our country, especially from southern part of India, Kerala and other where we have seen transmission from humans to elephants and well documented transmission. So bovine tuberculosis causing human tuberculosis, not well documented, but humans transmitting to animals is documented to some extent, but taking your cue, yes, as we move towards TB elimination, zoonotic TB, also non-tuberculous mycobacteria, will become an important component which will need to be addressed in future.
Thank you, Dr. Sachdeva. You all will agree this was a very informative, lot of my old doubts, and I think better than a prepared presentation where post-lunch everybody would have gone to sleep. So in fact, I would have gone to sleep. Yesterday I came late night after 1 a.m. So I thought I might go to sleep. So that's why I kept on talking. Now we come to the last
Thank you, sir.
speaker, Manoj Pardesi. He will be talking about his experiences and patient experiences living with AIDS. Manoj, please.
Thank you, Doctor. So, till the presentation. I just request, I know after lunch little bit, everyone is drowsy. So I request just pay 5-10 minutes attention. Keep your phone aside and let's hear the journey of patient empowerment. Since morning we are discussing on the patient empowerment. So NCPI is a national coalition of people living with HIV. We call it as a movement to improve the overall quality of life and keeping human rights at center. And I think that's the success of the overall HIV program globally. Because even globally, the HIV movement started with gay people rights. And that's what that right-based approach has been inbuilt in the whole HIV movement. Before going to this, like just since morning, like what I have heard is that there are prevention, care, and treatment tools are available. But because of lots of issues or barriers, it is not accessible or it is not affordable. Literacy, patient literacy is a problem. Quality is a problem. Stigma is a major issue. Political commitment. All these things are lacking, which is creating a barrier between the preventing or care tools to the end users. Can we go next? Okay. So, like this is a, can you, yeah, take it. So mainly, I'm not going to talk any data or number, but it's a like human face to the HIV epidemic. As we all aware that when initially people now are calling HIV, previously we used to call AIDS, and AIDS is equal to a death sentence. So from the death sentence, fear, shame, guilt, stigma, the movement started with the hope, courage, like being a positive, creating a positive change and contribute towards the HIV response. We not only asked for treatment, we sat together with the government, we sat together with the policymakers, stakeholders, we designed the intervention, how we want, how it will be received from the community. And that's the biggest strength we brought globally to halt and reverse the HIV epidemic. Next. Let's skip. These are the few cases where initially HIV patient, we don't call patient, but in today's conference, everyone is using patient. So I will use that word. So these are the stories where initially people put behind the bar and they fought, they took the legal way to fight the battle. And that's what I think today we have a HIV/AIDS Act in India, which is passed in the parliament in 2017. Next. So, like, I will not go read everything. Can you go back, please? Sorry, I was not aware that this is happening. Okay. So, as I like, initially it is very difficult even to cope within. And we thought we can only discuss with doctors because any disease is we have to first see to talk with the doctor. But in HIV, the peer support has helped a lot in building that courage and confidence. Next. So we realized that
if we have to, our voices should be heard, we have to build our capacity, we have to build our strength. So we heavily invested in collectivization. We came together, we learned a lot. Treatment literacy is one of our key strengths. Like even a illiterate person will be knowing what is CD4 count, what is viral load count, which medicine they are taking. That much treatment literacy has been happened in the HIV field. And that is because of like the whole investment in the patient empowerment has been put. So lots of us, like previously, now everyone is very familiar with the technology, but in 1995, even 2000, we still used to use that big computers, and one computer is used by 5-6 people. So, but we invested. The point here I want to make is that we invested in our capacity building, and the whole lots of people since morning is talking that somewhere we need to invest in patient literacy and empowerment. Next. So initially, like lots of barriers were there, especially access to treatment. I still remember the cost of 1 month medication for HIV was 68,000 rupees, which is highly impossible in the year 97, 98. 68,000 rupees per month is beyond even whoever will be the big businessman. For them also, it's very tough. We fought our battle. We fought with the patents. Lots of patent opposition we filed, and we make sure that treatment is accessible, then affordable. So the moment we also pushed government to have a free ARV rollout program, and we did everything. Like we did protest. Lots of us were kept in this Tughlaq police station for some while. They didn't arrested us, but they kept us hold for whole day, and then they released us. So we fought for our treatment, and as a result, like today, treatment is the Indian ARV is not only catering to India, but also the 80% people living with HIV population globally. Next. So these are some examples. We never, all opportunities we used, wherever we got the opportunity, we fought for against the patent, we fought against the affordable prices, and also we fought about the latest drugs should become as part of the treatment rollout. Next. Okay, let's go next. So here is the topic which we have been given, like HIV lessons. So patient empowerment, involvement in planning, decision making. Then the most important is we also played a role of peer. So services given through peer is one of the key change maker in the HIV intervention, and that giving face and voice to the epidemic has helped in controlling and also for patient like living a healthy life. TB, sorry sir, don't take it personally. TB is still a medicalized approach. Tokenism approach towards community engagement, and besides high level political engagement, infections are still rising. Like, and lots of reasons, lots of barriers, not only the things, but one of the things we see that if patient engagement will be ensured, we will also make health system accountable, and then it will be a win-win situation for both. So that is something which we can do, and same thing for diabetes, because HIV in diabetes is also increasing among HIV. Now because of the some NCDs are HIV ARV induced, and some NCDs are age specific. So NCD is a bigger issue in now people living with HIV. So overall, like globally, the HIV funding is shrinking, and the result is like there is a lots of kind of engagement has been reduced. Engagement at every level, not only at political level or bureaucratic level, but even the donor level. And then since funding is not there, then automatically even programs are getting affected. So now, to give you the scenario, infections are almost rising in every state. Infections are rising among young population, and that's not the like if we not able to control it, it will again bring back us to the era of early 90s. And most of the state AIDS control society here, the program is decentralized. There is a national AIDS control organization and a state level state AIDS control organization. So state AIDS control organization is not having a full-time person to look after the HIV program. And then it dilutes the leadership, and then that is also affecting in the implementation. Long COVID, I don't know like who are the researchers here, but we are noticing that people, those who took 3 vaccines, are their infections are not going early. Even the common cough cold is persistence for more than 20 days, 1 month. Even besides of 1 or 2 antibiotic course, it is not going. So I don't know whether it is a area for research and how best we can do it, but definitely research is needed among people living with HIV, those who had COVID and those who had vaccine, both. Can we go next? So I will just not repeat, but these are the things like which we can see to replicate in other responding to other illnesses. Next. So initially, actually, every death we used to personalize, and we used to think that okay, ab 6 mahine ke baad mera number hai, something like that. But today, at least, like because of lots of people's activism, we are still here, we are alive, and we are contributing. Thank you so much.
Thank you, Mr. Pardesi. It's very well covered many aspects. I have certain probes rather. Very important thing you said about peer group education. Peer teaches the safe behavior to the, and secondly is the empowerment of women as a decision maker. So summing it up, do you know anything? Can you say something about the pioneering project in India, Sonagachi project? So I would just like to highlight that because that was one of the success stories, Sonagachi project. And of course, Thailand was another country with 100% condom use. It eliminated, it had a very high rate, and particularly in the armed forces, and it brought down the Thailand. So something about the Sonagachi project.
Sorry, sir, I'm not much aware about Sonagachi project itself, but I know that there is this collective has been like able to create a mass kind of movement.
Good you don't know, because then I want to speak on Sonagachi project.
Yes.
Well, it just happened by coincidence. I was in Kolkata that time. I was in the armed forces. I was almost got involved with it, but didn't work out. But this study was done among commercial sex workers. You know, initially when the HIV first came to India, it was only focused to high risk. That is the commercial sex workers. It was all with promiscuous behavior or drug addicts. So that was confined. The epidemiology, that was the stage 1. And all places like Sonagachi in Kolkata is the red light area. So they had 5%, above 5% like other red light areas, the positivity among the commercial sex workers. So the All India Institute of Hygiene Public Health, Dr. Jana was the principal worker, and Professor Chakravarti, he made this project. And they took the leaders among the commercial sex workers, those who have good communication skills, and gave them the education. And these commercial sex workers, they went and to other sisters, those who are working in the red light area, they educated all others. So 100% education of the high risk group, commercial sex workers, and they empowered them also. Any client who would come, they would insist that they use a protection, otherwise they will not entertain them. So after couple of years, the prevalence in the Sonagachi area among commercial sex workers went down much below the general population also, antenatal mother. In fact, I was in FMC that time. I used to teach my students the stages of the epidemiology. Stage 1 is that high risk group, commercial sex workers, and then the bridge population, their clients, the truck drivers and soldiers, and then they infect their spouses, and it comes to the general population. So stage 1 is the high risk group, stage 2 is the bridge population, and stage 3 is the general population. Then I said there is a stage 4 also, that the Sonagachi project is so successful that to have safe sex, one has to go to Sonagachi. So that was the stage 4. The message to convey is that it can be done. It can be done because as it is, the stigma is associated with HIV and stigma is associated with commercial sex work. So by focused here, they remove the stigma among the commercial sex workers and they remove the stigma about the sex work also. So this is something a professionalism. And unfortunately now we just Dr. Mr. Pardesia was talking, again it is among youth, HIV is rising. This is a matter of concern. And probably I have seen in some countries, Western countries, when the antiretroviral, I mean, this can be a side effect of having effective treatment. Once the effective treatment is available, people become careless. Arey yaar, ye to treatable hai. So can it be that psychologically we have to study that also? It happened in the Western countries first. People become careless that the treatment is there. When they were concerned that there is no treatment, they were more careful. So this, of course, their drug addiction is also increasing and other things are also increasing. So it's a it is not an isolated problem. It's a psychosocial, lot of things are involved in this. Thank you. Thank you, Mr. Pardesi. I think this was a good session. Any questions from the audience?
One question, since HIV and TB need antiretrovirals and antitubercular drugs, we also know that the LMICs or South Asian countries are hotbeds for antimicrobial resistance because of incomplete treatments. And this is like a double-edged sword, that you do not have new treatments coming in because it takes a long drug development pathway. At the same time, you see risk behaviors are increasing, and then there are other comorbidities like diabetes that is increasing in infection. What can be done to manage this situation, and what can patient groups do to spread awareness around this?
So what TB program has done is a policy called universal drug susceptibility testing. So before you initiate treatment, you do a drug resistance profile, which is at least to rifampicin. So if you get a rifampicin resistance, then you do a full-blown DST. But if you don't have a rifampicin resistance, you treat them as DSTB. So that policy helps us to some extent to differentiate patients who need treatment for drug resistance versus who can be managed with a larger number is drug sensitive. Similarly, HIV also started viral load testing and testing for resistance. Fortunately, we don't find much resistance as on date. The kind of testing they have undergone, they have not found much high levels of resistance among HIV patients so far. But maybe as you scale up your viral load testing, you'll start getting up those numbers. But they are also sort of introduced that policy of shifting to another regimen. And that was introduced, I think, about 7-8 years ago. So I'm presuming they must have scaled up viral load testing and started categorizing patient who needs to go into which kind of treatment. But so far, they have not shown very high levels of resistance in HIV. The adherence tends to remain good in HIV patients. Courtesy advocates like Manoj.
So we are consistently advocating with NACO. So the current global fund cycle is actually now the money is allocated for the drug resistance test. And so that will start like after the April 2024.
Thank you, sir. Respected dignitaries, eminent panelists for giving deep analysis and overview on lessons learned from past to how to dwell and deal and prepare ourselves for future pandemics. But as we always say, precaution is better than cure. So yes, and we'll make sure that next time before the summit, we are better prepared. And yes, I insist we all should put our hands together for the milestones we have achieved and reached here. And we are discussing these important topics